Okay, see the numbers are still climbing, but in the interest of time, because we have a very engaging topic today that we want to make sure we cover and also leave enough time for a good discussion, we'll get started. Welcome to Behavior Support Rounds. My name is Einat, and I am the clinical manager for the Toronto Central Behavior Support for Seniors program based at Baycrest. Across the Toronto Central Lynn, and you may know Jordan Holland. Jordan is currently in maternity leave, and I'm replacing her for that period of time. For those that are new to rounds, I wanted to let you know that our behavior rounds occur on a monthly basis every third Thursday of the month from 2 to 3 p.m. These rounds are really meant to bring together stakeholders from different sectors to really share knowledge, tools, and best practices and promote integration across the sectors. Of course, with the goal to benefit the mutual vulnerable clients that we are all serving. The rounds are sponsored by the Behavior Support for Seniors program at Toronto Central Lynn and the Center for Learning, Research and Innovation at Baycrest. And we reach up to 50 different sites across the province. And we also share the recording of the rounds and archive them for later viewing on the Center for Learning and Research Innovation and the Behavior Support Ontario website. So just so you know where to find it, we will also send links to those after rounds. I would say that the success of these rounds is really and truly a system effort of multiple knowledge brokers, clinicians, healthcare workers, researchers, and leads across the sectors that are coming together really to contribute and share from their knowledge and expertise. And I really invite all the other sites and our stakeholders and partners to continue and participate and present at rounds. We are always open to suggestions and for more topics and opportunities to share, I would say, the really great work that is happening across the province. Such as I would say the work of our speakers today. Today we're going to hear from Dr. Christopher Kitamura, who is a staff geriatric psychiatrist at Baycrest Health Sciences and is waving at you right now. He's a lecturer in the Division of Geriatric Psychiatry at the University of Toronto. Dr. Kitamura's academic interests include late life addictions, optimal medication use, and sleep disorders in older adults. His other clinical interests include cognitive behavior therapy and the integration of telemedicine in clinical care and education, which is very, very, very important at this time more than ever. So thank you for joining us today, Dr. Kitamura. And joining—
Thanks, great to be here.
Great. And joining him is Cara Macanuel, that started her career in occupational therapy, working in the community at VHA Rehab Solutions in physical rehabilitation and geriatric health. She worked at VHA Rehab Solutions for nearly 7 years, 4 of which were spent as one of the geriatric health clinical leads. Cara has been working as a clinician leader at Baycrest on the community behavior support outreach team since the program was developed. So very close to a decade since it was developed in 2012. She continues to focus on capacity building, knowledge exchange, and helping clients with responsive behaviors residing in the community. I personally, back in the days, had the pleasure of watching and shadowing her in action. Today, Cara and Dr. Kitamura will be speaking to us about the topic of sleep disturbances in people with dementia and what works. So Dr. Kitamura and Cara, I would like to, our virtual stage is now yours. And I will jump in later on with some questions. If anybody has questions throughout the presentation, please feel free to ask them or kind of post them on the chat so we can respond to them throughout the presentation and after. And we will, of course, have a discussion. So Cara and Dr. Kitamura, please take it away.
Thanks, Anat. So I was just thinking with our title, we really should say sleep disturbance in people with dementia and healthcare professionals, what works. But anyway, okay, so Chris, if you want to go to the next slide. In terms of our learning objectives, what we really hope to cover in the next few minutes, first reviewing normal and abnormal sleep in people with dementia. Of course, get into causes and the impact of sleep disturbances in people with dementia. Review non-pharmacological and pharmacological treatment options for people who are experiencing these sleep disturbances. And we're gonna, hopefully if we have time, get into a case and get your feedback in terms of what you think would be applicable for that individual case that we're gonna talk about. Next slide. Sorry, Chris is doing the flicking of slides. So in terms of general sleep problems to consider in older adults, about half of the people in community have some sort of struggle in terms of sleep on the whole. In terms of the long-term care setting, you're looking at about 2/3 of the population. And unfortunately for us females, 59% can suffer from insomnia in older adults, whereas males, it's about 40%, a little bit lower. There are tons of different consequences to lack of sleep, medical concerns, higher risk of falls. I know your immune system can be significantly impaired if you're not getting enough sleep. From a psychiatric and behavioral component, I know personally if I haven't had a good night's sleep or if my kids haven't had a good night's sleep, we're definitely grumpier and a little bit feistier on the whole. So it can impact in terms of your mental state, in terms of depression, and just your ability from a cognitive standpoint in terms of how you're able to retain new information or problem solve, how you're able to process any dialogue that might be happening maybe around you. Memory, creativity, overall learning is quite impaired by problems with sleep. And all of this ties into quality of life. If you are a caregiver of somebody who has a sleep deficit, so for example, sometimes you'll get the day-night reversal, that's going to impact your sleep. You're going to be more worried about that person, what they're doing if they have a cognitive impairment in the middle of the night. And that's really going to impact your ability to cope and function as a caregiver, which might result ultimately in that person having to go into long-term care home. And of course, with all these things too, a higher risk of mortality. If you're at risk for falls, then you could break a hip and that can result in not a pleasant scene. So again, these are some of the major concerns that can come from sleep disturbances. Next slide. So just quickly to cover the main stages of sleep. And the reason why I want to highlight this is because when we're really evaluating sleep, we want to look at making sure that they go through this whole process of stage 1 to stage 5. It takes about 90 minutes to go through the entire cycle. The first stage, you're really looking at that light sleep stage where you're kind of going in and out of sleep. At that point, you might have those random leg twitches, which I know I'm always embarrassed by. I'm always nudging my husband saying, oh, sorry, that's just my little leg twitch there. I'm trying to fall asleep. Stage 2 is where things start to slower. So your breathing pattern starts to slow down, your heart rate starts to slow down, and your brain really starts to relax at this stage. Stage 3 and stage 4 are really important to highlight because this is the stage where you're in that deep sleep. And if you don't get to this state, you're not going to really feel refreshed in the morning. So this is really I would say, one of the more important stages you want to get into, where there's a slower wave of sleep. Your body is really in that reparative mode. Your breathing and heart rate continue to slow at that point. And then stage 5 is the REM sleep. So this is where you're in the dream state. You might have kind of those eye flicker movements. Again, your heart rate might change, breathing patterns and blood pressure change. Your temperature might increase a little bit more. But again, it's about a 90-minute process going through this entire state. Okay, next slide.
Great, thanks very much, Cara. Thanks everybody for joining, and thanks for having us both. Okay, so this is basically another way of looking at that last slide in terms of the stages of sleep, but here actually comparing the sleep of younger adults at the top and older adults at the bottom. And this is something called a hypnogram. So kind of across the bottom, the horizontal axis is sort of the time throughout the night, if you will, so the hours of sleep. And then along the vertical axis are the stages of sleep. Okay, so the top would be wakefulness, right? So not asleep yet. And then the stages, as Cara had mentioned, and just highlighting some general differences. So this is like not looking at the clinical or pathological sample. This is just looking at older adults generally compared to lower adults. Some of the things you'll see is that older adults on the whole have more awakenings, right? So you see more times the hypnogram comes up to the awake state through the night. And with that, more time spent awake during the night, older adults have what's called less efficient sleep, right? So they're sleeping less of the time that they're actually in bed. A couple of other things that are noteworthy. Older adults on the whole get less into that slow wave sleep as well, the stages 3 and 4 that you'll see. And they also have less REM sleep. And REM sleep is actually a stage of sleep that increases generally as we go through the night. But into older adults, they often have less of the REM sleep. And the slow wave sleep, as well as the REM sleep, they're both sort of medically and psychiatrically kind of cognitively restorative changes. One thing that's not captured on here is more of a daytime phenomena, but it is true that older adults are more likely to have naps during the day and may have some impact on, for example, the fact that there is more time spent awake at night. Okay. And in terms of why older adults experience some of these sleep changes, it's more fragmented sleep, less of the deep and REM sleep, less total sleep. There's a few physiological and behavioral causes, if you will, and this is, again, generally speaking. So we're not talking about specific medical or cognitive conditions, but just in terms of what it is about aging. And often because of older adults are less likely to be exposed to light or be outside and active during the day, they might get less exposure to actual daytime light that regulates the melatonin levels that affect sleep. Also just changes in the eye and the sensory input, the sensitivity to light, that again can affect melatonin levels. Changes in routines, and there's this German term called Zeitgebers, which is a German term for kind of the routines that we all have throughout the day that sort of set our biological clock, if you will, right? So we all are going to work during the day, we eat meals at a certain time, we perhaps talk to family and see friends at a certain time, less during the pandemic, seeing them in person, exercise, things of that nature. And some of those routines, like less daytime activity, less exercise, that might affect people's sleep routines when they sleep. There's some actual changes at the level of the brain, and there's this area of the brain deep in the brain, the hypothalamus, called the suprachiasmatic nucleus, which is kind of the heart that sort of sets the sleep schedules. And also I mentioned the effects of naps. Older adults more likely to have naps on the whole. Okay. And in terms of, still me? Yeah, I guess. And people with dementia, like what specific sleep challenges do they encounter? Well, really, just about any form of sleep disturbance or sleep disorder is more common in people with dementia, right? So just primary insomnia, just not sleeping enough or not getting a good enough sleep, subjectively restorative sleep, excessive sleepiness, and of course, those can certainly be related. Circadian rhythm disorders are quite common. So the meaning of that is typically most people would have a specific block of sleep at night or a time at night during which most of the sleep happens. But in people with dementia, often it's broken up, right? So they might be sleeping blocks during the day, some at night, but there's not a clear period of wakefulness and sleep period. Sleep disordered breathing, of course, think of sleep apnea. Parasomnias. So these are abnormal movements during sleep. One very common one called REM behavior disorder. So usually the body and the muscles, except for the breathing and the eye muscles, are relaxed during REM sleep, but in REM behavior disorder, that's not happening. So there's abnormal movements. Restless leg syndrome, and related to that, something called periodic limb movement, which Cara talked about. And most people experience both. So often people that have restless legs, which is a kind of that, like it says, that sensation of restlessness, usually in the evening, and gets better with some movement, often also have periodic limb movements during the night. And you can imagine older adults who are more likely to be living in institutions and retirement homes and nursing homes. There's certain environmental factors, and perhaps many, that can impact sleep. You know, think of noise and light and sound and routines when nursing care happens, when medications are administered. And certain dementia-specific treatments, like the cholinesterase inhibitors, like Aricept or Exelon, a side effect can be insomnia. And there's certain medical conditions, of course, that can disrupt sleep. Probably some of the more common ones being pain, acute pain, chronic pain, as well as nocturia, so needing to urinate during the night. And certainly problems like UTIs, problems with prostate, BPH in males, but other things too. Delirium, of course, one of the hallmarks is disrupted sleep. Certainly all psychiatric conditions basically can have as a symptom a sleep disturbance, depression, and anxiety, of course, being quite common. Acid reflux, right? Think of acid reflux and then laying down when we're trying to sleep, right? So that can be a trigger. Obesity, which is a risk factor for sleep apnea as well. Cardiac problems, things like heart failure in particular, and constipation and diarrhea. Okay, and over to you, Cara.
This is me. Okay, so when you're looking at assessing the person's sleep patterns, first and foremost, you want to start with looking at sleep history. So is this a new behavior where they're having trouble sleeping, first and foremost? If it's long-standing, what has been the pattern? So is it that they've historically had difficulty falling asleep, or is it a matter of they have difficulty staying asleep, so they fall asleep and then they're waking up frequently? Do they have long-standing history of insomnia? Again, trying to capture a general sense of their sleep patterns on the whole. My team likes to use the Dementia Observation System, or the DOS, or a sleep log. And this really looks at breaking down the day into half-hour increments and looking for patterns in terms of that sleep. So this is really beneficial if you have a private caregiver or somebody who's willing to really put in the time to capture this. May not be an option. Certainly in a long-term care home setting or retirement home setting, you might have the means and the staffing to do this, but in a home environment, maybe doing something a little less concrete, like a general sleep log, might help guide them a little bit. But this is to really help look at, are they getting through the 5 cycles? So again, if you're looking through a DOS and you're seeing that they're only sleeping for an hour, maybe 45 minutes or something, you know for sure they're not going through the 5 stages of sleep. Doing medication review and definitely looking at the timing of the medication. I've had some clients who will be on a water pill at night, and obviously that's going to cause them to be up and urinating all the time. Again, looking at the medications that might have a sedative component. If it's given earlier in the day, that might result in the person want to nap more often throughout the daytime. So it's really important to delve into the medication as much as possible. If you have the TC-Lin involved, they do have pharmacy on that team, so you can pull in that added support in the community setting, or of course using regular community pharmacists as well. Doing blood workup and urine analysis, as Dr. Kitamura said, you want to rule out delirium or urinary tract infections. You can also look at it from the perspective of if they have low iron levels or B12 levels, any issues with their thyroid. All of these factors can weigh into their sleep patterns. Diet and alcohol intake is important as well. So if you can keep a log of that, if they're obviously taking in a lot of things that might have caffeine in it, so something as simple as chocolate can result in a change in the person's sleep patterns. Alcohol can have a sedative component if you're absorbing too much in your system. But also there's food that has diuretic components, like asparagus, for example, has a diuretic component. So that might also result in having to get up and go to the washroom more often. Pops and that sort of thing obviously have a negative effect on sleep as well. So you want to look at that as a component. Pain assessment, as Dr. Kitamura said, ruling out pain is really important. We on the community behavior support outreach team really like to use the pain assessment in dementia, and this allows us to really look at understanding whether the person has pain from the nonverbal aspects of things. So I don't know if everybody's familiar with this assessment, but it really looks at the person's breathing patterns, their wincing, their rubbing of joints, that sort of thing. So again, it really is helpful in terms of ruling pain out. I put here the Cornell scale for depression in dementia. Certainly there's multiple other assessments like the geriatric depression scale. This one's a really good one just to, again, zone in on the mood component of things, and it allows for the caregiver's perspective on what's going on from their observations. And an overall environmental assessment. This may not be feasible right now with COVID, but before COVID, it would be really helpful to go in and take a look at whether there's a lot of lights going on, if there's a lot of noise or glare, or even shadows in the environment that can be misperceived. So these are all things to really look at, and the temperature, of course, of the room. We'll get a little bit more into specifics around that in a few slides. And certainly if the person can tolerate, you would really encourage like a formalized sleep study would be beneficial. So polysomnography, I can't even say it now. I also had a root canal yesterday. So polysomnography, there we go. So not always tolerated by everybody in terms of these more advanced studies, but certainly if they can do it, that would be beneficial to see if they're, again, going through those stages of sleep. Next slide. So starting to get into the non-pharmacological interventions, again, we've talked about a few of these things, ruling out the side effects of medications, treating the pain, the psychiatric conditions. One thing that's really important is to have a firm wake time for the client and bedtime for the client. So routine is really, really essential for people with dementia, but really applicable for sleep as well. If you can try to have it as a firm, like go to bed at 10 p.m. or try to at least get in the bedroom to get sort of the nighttime routine started at that specific time, and then a waking up around 9 o'clock or whatever it might be. But again, making sure that we have consistency in terms of that timing. Wayfinding cues and visual cues is important as well. If the person with dementia is getting up in the middle of the night to find the bathroom, if they don't remember where the bathroom is, certainly that can prolong their ability to get back to sleep because they've been spending the past hour just wandering the hall back and forth and not being able to find the bathroom. So putting up signs, better lighting in the hallway to help guide them in terms of where the bathroom is and how to get back to their bedroom as well. If they can tolerate a CPAP machine, if they have sleep apnea, again, not well tolerated, but certainly will be helpful if they can support wearing that. Other options, there's mixed reviews on, but bright light, so using those seasonal affective disorder lights, using massage and acupuncture if tolerated, aromatherapy, so lavender scented lotions. They do have lavender scented pillowcases as well, and mindfulness, so looking at meditation if possible and relaxation techniques. Next slide. So delving into sleep hygiene, again, you want to look at setting the environment. So setting the scene for that person. Again, limiting noise if possible. Sometimes having like a white noise machine might be helpful just to help drown out any other excess noise. If they're in long-term care, as Dr. Kitamura said, there could be a lot going on. If they're in a home environment, even if they're in a condo or apartment, you could have noisy neighbors. So you want to try to drown that out as much as possible. In terms of temperature, the research really says around 68 Fahrenheit, which is about 20 degrees Celsius that you want. And then trying to structure things like nighttime bath or shower just to help relax the body and get ready mentally and physically for bedtime. When looking at this, the sleep schedule, again, having firmed outlines in terms of that timing, but also limiting the naps. If that person loves to nap, trying to shift it to earlier in the day as much as possible. So before noon or before 1 p.m. and really limiting it to about an hour or an hour and a half at most in terms of that nap. Reducing stimulants is important. So again, we already talked about dietary stimulants as well as alcohol, cannabis. I know I did see Marilyn is on the call here, so I'm sure she can chime in later. But some of these factors can definitely weigh into sleep, although CBD oil, I know there is some research supporting its benefits for helping with sleep as well. Increasing daytime exercise. So you want to try to get them to be as physically active as possible and get them exposed to light, so natural light, to help get through the circadian rhythms. There's multiple theories in terms of supporting, again, that increase in physical activity and exposure to light throughout the day. Eating a light bedtime snack is really helpful. You want to avoid getting to that state of hypoglycemia where they're waking up because they're hungry. I always suggest putting out a snack, a protein or something that helps them feel a little full, but not excessively so. Avoid, obviously, spicy foods closer to bedtime, anything that's going to make you feel bloated. That's really going to impair your ability to get a good sleep as well. Reducing fluid intake in the evening. I generally go with the rule of thumb of about I would say 3 hours before bed, you want to try to avoid getting any fluid in them, because then they're going to be up and having to go to the washroom quite often. I appreciate that sometimes people need to take some fluid to help with taking medications at night, so I just talk about eliminating that as much as possible. I've also had cases of people that are just constantly wanting fluids, so I just talk to the caregivers about only giving smaller amounts, and if the person gets upset, then give them smaller cups so that they don't see that it's a small amount. TVs, iPads, iPhones all have the blue screen effect, and that can suppress melatonin, which will impact our ability to fall asleep. And sometimes having those environmental factors like having a clock in the bedroom, you're just going to constantly be staring at the clock, and you'll think, oh, I have to get up in the morning, or they might be thinking, I still have to go to work. And just that fixation on the clock can really upset that person and get them stressed and anxious about it. So looking at treating insomnia, again, addressing the underlying environmental causes, we always want to try the non-pharmacological approaches first. So cognitive behavioral therapy in insomnia. So CBTI is one of the main principles in terms of helping from a non-pharmacological perspective. And then you're going to be really looking possibly as other options if the non-pharmacological options don't work. And that's looking at short-term periods of sleeping pills. Next slide. So what is cognitive behavioral therapy for insomnia, or CBTI? There are 4 main components that we'll get into. So sleep hygiene is the first, then stimulus control, sleep restriction, and cognitive interventions. So we're going to break that down. Next slide.
Great, thanks. And we already talked about the first one. Thanks, Cara, about some of the sleep hygiene principles. So I'm going to tell you a little bit about the next 2 that you may not have heard about as it relates to CBTI, or sort of therapy for sleep. The first one you probably have, it's called stimulus control. But the idea here is that we want to move towards a state where people are only using their bed for sleep, and any other activities, doing things in bed, watching TV, being on their phone or iPad, you want to get those activities not happening in the bed, or ideally not in the bedroom entirely. And the other part of it is if people are not sleepy and not sleeping, you want them to leave the bed, right? And the idea here is that, you know, chronic poor sleep is a learned, trained condition. So we want to retrain the body and the mind to associate that being in bed means sleeping, right? So not going to bed until people are sleepy. And again, often if people are in bed and they find they're not sleeping, then to leave the bed. So often people talk of the 15-minute rule. Some people say half an hour. But again, just the idea is if you're not sleeping, you want to leave the bed, okay? And I mentioned the third part is using the bed just for sleep, okay? So that's called stimulus control. I even try to tell people if they're leaving the bed, you don't want them to even just sit, you know, up next to the bed. Try to actually get right out of the bedroom entirely and do something boring, you know, read a boring book. Don't start replying to emails. Don't watch sort of an action movie or things like that, of course. Maybe do some mindfulness during that time, a little bit of breathing exercises. Those are some good strategies. And then the next part, which requires a bit more of either a motivated patient or a good caregiver who's going to help, something called sleep restriction. So the principle here is that often people who are not sleeping well are not sleeping that efficiently. So they might be in their bed for 10 hours or 11 hours overnight, but may only be getting 6 hours of sleep during that time. So the idea being here that you want to actually reduce the opportunity for sleep. So reduce the time in bed. And you do that both by fixing the wake up time and then also delaying the bedtime, right? And typically we would try to restrict the time in bed all the way down to someone's total sleep time. So for example, if someone sleeps 6 hours a night in total, we get that from the sleep diary, and we set a desired wake up time of 7 a.m., that we're actually going to tell them to go to bed at 1 a.m., right? So you're going to allow a time in bed from 1 a.m. to 7 a.m., right? And as you can imagine, what might happen then is people are more likely to be sleepy and be sleeping more of that time when they're in bed. So the sleep efficiency will increase. And once people are getting more efficient sleep and they're training themselves to sleep more efficiently, then slowly we can work earlier the bedtime, usually in 15-minute increments, right? Until we get to hopefully a point where people are still sleeping efficiently, but they're also sleeping an adequate amount, right? The ideal number of hours of sleep, which is going to vary person to person. And then beyond that, like any CBT, so there's a cognitive part of it. A lot of the work in CBTI is the behavioral piece, but we can look at some of the unhelpful or untrue thoughts related to sleep and try to challenge them and change them, right? Because thinking errors and unhelpful thoughts about sleep lead to worry. which can further impact sleep. So some of the examples of unhelpful and possibly untrue thoughts people have about sleep is, I can't sleep without sleeping pills. I'll come back to that in a second. You know, if I don't sleep well, I can't function, right? And often I tell people, well, you didn't sleep well last night, but hey, you made it to this appointment, right? Or you seem awake right now. You just had a nice visit with your friends or your family. If I can't sleep, I should stay in bed and try. Of course, we kind of debunked that, right? With the stimulus control. If someone's not sleeping, they should leave the bed. I slept poorly last night, so I'll probably sleep again bad today. Well, also, I often tell people that something called the sleep drive is one of the biggest factors in sleep. So if somebody's more tired and they have had, you know, a bad night's sleep the night before, they're more likely actually to sleep better the next night. Okay. All right, and just briefly, a few studies. I won't get into too many details here, except to say that there are a number of studies that that show that CBT for insomnia works. Now, there's much fewer studies that look specifically at people with cognitive disorders and people in institutions, but there's a few. So I'll show you a couple. So this one here is often studied. It's the NIGHT AD study, and it was in individuals with Alzheimer's type dementia, a study of 36, which is not bad. It was a 6-week study, and here they used combination of training sleep hygiene, walking, some daytime exercise, and they used the light box in this study. The control was just some sleep education, sleep hygiene, and the experimental group did have less awakenings and slept more of the night. And also their moods were better. That's the NIGHT AD study. There's also a study by Cassidy Eagle that looked at, again, 28 people with mild cognitive impairment. They were in retirement homes. The previous study was in the community. These ones are people in retirement homes. They did a bit more comprehensive CBTI. They did sleep hygiene, relaxation, stimulus control, and sleep restriction. Some of the cognitive approaches, and again, improved sleep efficiency. And one of the scales that we sometimes use to assess sleep is the Insomnia Severity Index. So that improved, they were sleeping better. There's a big study in the UK that's just getting underway, looking at people with dementia in the community. So there's no results yet. And then if we look at older adults just generally, you know, the verdict is in, CBTI works in older adults, okay? And there's been some actual positive reviews, meta-analysis and a systematic review. Okay. So getting closer to the end, I want to say a few things though about hypnotics. I know not everybody in the room is a prescriber, but everybody I think is encountering people who are on medications, and that's probably part of our work and our assessment. So it's good to know, even if we're not a prescriber. In terms of the sleeping pills, as Cara had mentioned, really not a first line treatment. And generally speaking, if we're looking at having somebody on a sleeping pill, we want to try to keep it, you know, for as short a period as possible. And presumably there should be sort of a short-term disturbance in sleep. Sleeping pills make less sense for people that have had lifelong bad sleep routines. It makes more sense, for example, people that might have just been admitted to hospital, right? Or just come home from hospital and are recovering from a condition with maybe acute pain, for example. And with sleeping pills, generally speaking, lowest effective doses. In contrast to a lot of prescribing practices for older adults, when we like to think regularly scheduled, you know, every day, certain times of the day, this might be one exception where we want to use them just when needed, so just as needed dosing. You want to use pills with what are called shorter half-lives, which means they don't accumulate in the body and they don't have an extended effect throughout the day, which reduces the chance of sedation the next day and cumulative side effects. And you want to avoid, at the same time, taking other sedatives, things like alcohol, other drugs that are sedatives, cannabis. And in terms of the general classes of sleeping pills, that was a question. So is CBTI available at Baycrest? We'll talk about some resources. I do a little bit of CBTI, but you can imagine my one person can't do so much. So there are a couple of resources that I'll share where you guys can incorporate some CBTI and do it yourselves too. And there's a couple of psychiatrists, Mark Rappaport at Sunnybrook. If you do some work with patients there, he does a fair bit of CBTI, but not other clinicians that are OHIP covered that I'm aware of. Okay, and private therapists, I'm sure would offer it too. Come back to that. So just going back to the sleeping pills, The general classes, the main one, or one that you'll often see, that what are called the benzodiazepine receptor agonists. So the benzos, things like Ativan and Valium, and Z drugs, things like zopiclone, zolpidem. This class of medication, and they're quite similar. There's some evidence that maybe the Z drugs are less likely to cause certain side effects and are maybe less likely to cause a physical dependency, but that's not, they're not totally benign. Certainly they have similar types of risks. And they are associated often with cognitive impairment, memory impairment, falls, and developing a physical tolerance, right? So physical addiction. Antidepressants, and this is a heterogeneous class, things like trazodone, which arguably is maybe a bit more safer than some of what are called the tricyclic antidepressants that were in favor, you know, in years past, but are less used now. Some of them do have sedating properties. So do get still some use. But these medications all can potentially affect the heart rhythms, something called the QTC, can prolong QTC. Antipsychotics have a number of side effects, as you probably know. The Parkinson's-like side effects, weight gain, cholesterol, can be also quite what we call anticholinergic, causing constipation and dry mouth. And they can have some risk of stroke and cardiac problems too. So aren't really first choice. Amongst this list, melatonin would probably be one of the safer ones here, and it does have some evidence in older adults. There's a bit more evidence for the sustained release forms of melatonin. And typical dosing, which I often get asked, would be starting around, you know, the smallest pill you get in the pharmacy, which would be 3 milligrams. Some people buy the 5 milligram pill, and it can go as high as about 10 milligrams. Pretty much free of side effects, except rarely some nightmares have been reported in people taking melatonin. Antihistamines, so things like Gravol and Benadryl, are used a lot. The good evidence is pretty much lacking for these pills. And pills that have a lot of anticholinergic properties also can be a risk factor for delirium. So pills like Gravol and Benadryl are not totally benign, even though they are over the counter. Magnesium does have some evidence and is fairly safe. Cannabis is a complicated one. I'd be curious for Marilyn's thoughts in the discussion. And cannabis, of course, is a very heterogeneous bucket. And I think there's probably still some work to be done at saying, you know, if and what types might be the most helpful. But there is some evidence that cannabis can suppress the REM sleep, which is an important part of the restorative stages of sleep too. There's a question. Are there any studies into the role of nutrition on improving sleep? Yeah, specifically tea and toast eating.
Tryptophan.
Tryptophan too, yeah. So tryptophan is a precursor to melatonin. So you think when you eat turkey, people get sleepy. So there is some connection through melatonin there. It's on the same pathway. There's certain teas like herbal teas, chamomile tea, or even like the sleepy time teas, bedtime teas that might be worth a try. Cara mentioned certain foods to avoid. Anything else on nutrition while we're on? Oh, there was a question.
Well, I was going to say, just be careful with the teas, because again, you're increasing the fluid intake. So it's a balance, and look at the timing of the tea. If you are going to try like a chamomile tea.
Right. Yeah. Certainly not the caffeinated teas, which would also be diuretics too.
Marilyn saying CBD can also present risk for falls due to sedation.
Right. And that's certainly an at-risk time when people are getting up at night when it's dark and maybe have been lying for a prolonged period. So the blood pressure sometimes hovers a bit lower. Thanks, Marilyn. Okay. Good. Okay. So Cara's going to finish off with a case, and then we'll share a couple of resources. Then we'll do some more questions.
Thanks. Okay, so for this specific case, this was a gentleman residing in private home, so in the community, a 75-year-old male retired engineer, and he had his wife living at home with him. In terms of his little bubble of support, so the circle of care consisted of TC-LIN care coordinator, TC-LIN personal support workers, and he was actually on a special program that offered an increase, a short-term boost of personal support worker hours to help monitor what was going on from a sleep perspective and risk, and looking at fall prevention. So he had a personal support worker from 12 p.m. to 4 p.m. and then 8 p.m. to 8 a.m., so overnight. He was also followed by a neurologist, a geriatrician, and a family doctor. And then my team was pulled into the mix mainly because of his sleep disturbances. Medical history consisted of a slew of things, just to highlight the ones that really factor into his sleep. So the Alzheimer's disease, of course, hip fracture in January 2020. Other key things to highlight would be the history of chronic constipation, bowel obstruction, anemia, sleep apnea, asthma, ADHD. So all these things are really important to highlight because they can weigh into his ability to sleep. So specifically for him, next slide, the main concerns were long-standing sleep disturbances since 2013. When I asked those key questions in terms of sleep history, as I mentioned before, that's sort of a good gold starting point. I found out that he was self-medicating once upon a time with sleeping pills. And this was a concern from the prescribers at this point because they really didn't want to venture the route of doing medications. They really wanted to look at the non-pharmacological perspective. Previously, he did try melatonin, didn't have a lot of success. I personally find that melatonin is touch and go. Some people swear by it, other people find it's not effective whatsoever. So for him, he really didn't find it to be effective. So I did venture down the route of doing DOS tracking because we had the advantage of having those personal support workers there. So we did really narrow in on the sleep patterns. And from that DOS tracking, we did about 2 weeks of tracking. And we saw that there were daily naps happening midday, and it was ranging from about a half hour to an hour and a half in terms of the length of that time. There was no set bedtime, so it would fluctuate from anywhere from 8 p.m. till 11 p.m. And overall at night, his sleep would range from anywhere from a half hour to 3 hours at most. And again, to go through that the 5 cycles of sleep, again, you're looking at the 90 minutes to get through to the REM sleep pattern. So he sometimes would get through to it, but not always. And one of the main causes that he was getting up to use the washroom. So he kept waking up. For him specifically, he felt that he would have the need to have a bowel movement. So he would be up, and then wouldn't get back to sleep necessarily right away. And this would really throw a wrench in terms of his overall sleep patterns. Next slide. Okay, so we're going to turn it over to you guys just based on what you've heard from us today. And people can just use the chat boxes at this point. What would you suggest for this specific case, hearing what I just mentioned? Or you can unmute yourself if that's easier than typing. Maybe we put everybody to sleep with our talk.
Yeah, I'll go back to the case too, so if people want to have another look at some of
the responses are starting to trickle in, and there is no right or wrong answer. It's really anything that comes to your mind.
Yep, reduce fluid intake, set bedtime, limit the naps, yep. Review medication, increase daytime activity, yep. So his physical activity throughout the day fluctuated. He would go for occasional walk, but outside of that, he didn't have a lot on the go. Review toileting, yep. More fiber in diet. Good, so that links in about the dietary question as well, the increasing fiber to help with the bowels for this specific gentleman. Keep him busy, review and monitor pain, bowel routine, great ideas, yep. Explore frequency and voiding, blood pressure, address constipation. That's great. Any other last thoughts or any tricks that other people have used in terms of dealing with sleep issues? Review comorbid conditions, soft relaxing music at bedtime, environmental check, yep. Preferred sleep attire. One thing I actually didn't mention here too is that he had skin irritation, so he would often be scratching as well. So that was something that weighed into his ability to sleep throughout the night. Outside walk, yeah, changing time of medications. Great.
Great. Okay. We've
Perfect.
done pretty well.
Thanks,
then,
everybody.
Cara, I guess, with that feedback. Okay.
So these are the suggestions that I had, and it's quite aligned with what everybody else was proposing. So again, looking at a physical examination to rule out Mainly things around his bowels and pain, of course, but because he was often getting up, as he said, to go to the washroom. So we really wanted to look at that constipation, look to see, because he kept trying to frequently go to the washroom, were there hemorrhoids because of those attempts, or rectal tears or anything to that effect. As I mentioned, he had sleep apnea, so we did talk about using a CPAP machine. It wasn't an option that was favorable for him. As I mentioned before, it would be tricky to get anybody to wear a CPAP machine, let alone somebody who has a cognitive impairment. We did talk about avoiding the excessive napping. Again, as I mentioned, try to aim for earlier in the day for about an hour, hour and a half at most. Avoiding spicy foods, so that dietary component we did talk about, as well as the small snack before bed. Environmental standpoint, again, the white noise machine, setting the room temperature, looking at darkness. As Dr. Kitamura mentioned about the sleep patterns of having him lay in bed, and if it was 15 minutes where he's still awake, getting him out and doing a calming activity. For him specifically, I did find out that he was watching a lot of news before bed. So we talked about maybe changing it to something that's a lighter topic, especially in light of COVID. We really want to avoid exposing him to any programs that would really set off any anxiety or get his brain going. We talked about avoiding fluid before bed as much as possible, and then the increase in activities. Because the personal support workers were there at night, we did talk about shifting the timing of the shower. For him specifically, he was insistent upon showering earlier, so I didn't really get the buy-in there, but for some people this certainly could help, as I mentioned before. And we did talk about the aromatherapy and the other alternative approaches in terms of muscle relaxation and mindfulness. And then that consistent bed and wake time that I said is really important. We did talk about that. And then just the increase of exposure to natural light. So pretty much everything that everybody mentioned there. I did see a question, does laying down increase the need to void for some folks? I think it can potentially, it depends on how the bladder is sitting. I don't know, Dr. Kitamura, if you have any added bits for that one, but it depends on their position probably as well.
Yeah, I guess there's certain positions that'll compress and create that sensation. I also wonder if it's if people might have it might be less a medical thing, but just more once people lie down, there's less distractions, right? Maybe there's less on their mind, and then maybe the mind gravitates to I need to urinate, or I'm not sure. Has that been your experience, Rebecca? Have you seen that in some of your patients, that there's the positions that you want to avoid or that are particularly helpful at one client? Okay, thank you. Yeah, maybe we could talk about it a bit more shortly.
And I was going to say with voiding too, I've discussed about what's referred to as double voiding. So this is where you get the person to use the washroom, like go sit on the toilet, stand up, and then sit back down again. That standing and sitting down shifts the position of the bladder, which might help if you're not fully releasing the bladder. So that's one thing to really try to encourage the patient to do before bed. I did see the question about mattress assessment. I know another person flagged that to me earlier as well, just in a private message. Definitely, you want to be looking at it from an environmental standpoint. So are there concerns in terms of comfort of the actual mattress themselves? Do they need pillows to accommodate added comfort if they have back pain, maybe having a pillow in between their knees? Just speaking from me being pregnant twice, I know certainly having lots of pillows was helpful for me at that time. So really accommodating as much as possible. If it's an old mattress, maybe it needs to be flipped. So again, definitely from an environmental standpoint, that's something to highlight. So after all those suggestions, the situation was as follows. So he had a more consistent bedtime set up. So they were really aiming for a 10 p.m. Sleep time, and getting up around 9 a.m. was the goal. One thing to mention just on the side note, I've had some patients that would sleep until 1 o'clock in the afternoon. If you have that pattern, trying to get them to wake up maybe a half hour earlier for the first week. So aiming for 12:30 for 1 week, and then the next week doing a half hour earlier than that, 12 o'clock. Using some of that, the seasonal affective disorder lights to also help get them awake is one thing that you can consider. For him, thankfully, with trying all those suggestions, we did get bigger blocks of time for his sleep. So we had up to 5 hours versus the previous 3 hours. And because of that, he was having more of a consistent pattern of going through those 5 cycles and feeling a lot more refreshed in the morning. There was no longer a need for the evening personal support workers because, again, the main concern was that he was at risk for falls when he was waking up as often as he was. So the TC-LIN did cut back on that. The one thing that was still pending, of course, with COVID was doing more of that physical examination, although the client himself was reporting no concerns in terms of hemorrhoids or rectal tears that he could tell. But certainly that's one thing that I would say would be important to follow up on just going forward once things are a little bit more open with the COVID world. Next slide.
All right, thanks. And Stacey, I saw your message that there's going to be some polls. So will they just show up on the screen, I guess, when they're ready? So we'll keep going. Yeah, okay, great. So I'll keep going until those do. Just finishing with this last couple of things. There's lots of resources around sleep. This is one through what's called the Center for Effective Practice. This is the family physicians in Canada have a good repository of tools, and they have some great resources for managing insomnia. So it's pretty dense. There's a lot of stuff here, but it's if you want to really dive in deep, check that out. There's some manuals. There was a question about how can you access CBTI? Well, you can learn it and do it. There's only a finite number of actual principles. So and these manuals are pretty good. They are very kind of step by step, session by session, and most can be and CBTI can be adapted for people with cognitive impairment, as I mentioned. I use the one on the left by Perlis, quite like. There's a great website. You might know there's several initiatives recently around deprescribing medications that are potentially harmful. There's a group called the Canadian Deprescribing Network out of McGill, and they have and it's a lot of resources geared right towards patients and family members. And they have something called the brochure, the Empower brochure, and it talks about getting people off who are dependent on sleeping pills off, and talking about some of the alternatives and Q&A and myths about sleeping pills. Okay, I want to get to questions. So this is just a summary to not accept, poor sleep quality and poor sleep, and sleep problems are treatable. Look at some of the causes first: medical, psychiatric, environmental. There's pieces and other systems, to formally assess. Try the non-pharm first, and CBTI works. I've shared a few pearls around hypnotics, and there's some resources. Okay, good. Okay, so we had, if people are not sleeping one night, then can read through our resources. Okay, great, 2 questions. So there they are. So I'll let you.
That's great. Thank you so much, Chris and Cara, for this presentation that is very practical and full of resources. That I think people will definitely find helpful. Our poll questions are starting to. Please respond. I think our speakers really deserve your feedback, and we rely on that feedback to continue and create engaging and helpful sessions for you as our audience. So we want to leave a few minutes for discussion. Any questions that weren't answered? If people wanted to share what they're taking from today, if something shifted in their thinking about sleeping disturbances as a result, or anything that you would like to share about the presentation. You could either share through the chat or unmute yourself. And while people are thinking, I would say that I saw in the chat, Brittany, you asked about how long before sleep do we need to stop giving fluids? And you got one answer from Dr. Kitamura, 1 hour, and one answer from Cara. And I thought perfect, because it's never really an exact answer. It's really a bit of a trial and error and adjusting to the specific person. Cara and Dr. Kitamura, would you agree with that statement? Anything else you want to say to Brittany and others about that?
I think when it comes to all non-pharmacological interventions, one thing will work for one person one day and not the next, and different people, and it's really just getting into a rhythm as much as you can. I did see Nikita was mentioning that it is hard to get into these rhythms and routines in a long-term care setting. Definitely, I mean, I don't work in long-term care, so I don't know, Dr. Kitamura, if you can sort of highlight that, but I could see, especially from an environmental standpoint, that there could be a lot of challenges and other residents potentially that are weighing into your ability to sleep as well.
Mm-hmm. Yeah, I actually don't work primarily in nursing homes either, but I certainly deal with people, support people through the transitions and in and out of hospital and in retirement homes. And there certainly is only so many variables you can control. So I guess also having a certain degree of humility, right, when trying to support people with sleep, and also knowing that, you know, a lot of sleep is about sort of the routines and the patterns that people have learned throughout their life, right? And some people who have been a chronically poor sleeper, you know, it might be unrealistic to expect overnight that they're suddenly going to be having great sleep, and being creative, I think, like Cara said. So this is a good group. I think we're preaching to the converted there, right? Because BSOT is all about, I think, trying to find sort of creative solutions, right, to problems.
So there are some great comments coming out in the chat, speaking to the challenges of the difficulty to adjust to the current rhythms and routines in long-term care. Heather is saying that through COVID, we've seen more instances of anxiety and more complaints of sleeplessness. So that's definitely taken a play. A great comment. And some people are stating that they really like the white noise idea, especially in a long-term care where it could get very loud.
Elizabeth asked about OT and PT assessment and vitamin D. So Elizabeth works on our team, and I know, you know, I'm an occupational therapist, so definitely, I mean, and I did see somebody posted about the role of using like urinals and commodes beside the bed, maybe a bed rail, a bed alarm, or something to help signal to the caregivers that they're trying to get out of bed, so that they might be able to help in terms of wayfinding at that point. And just looking at the mattress again, that's where the occupational therapist can really chime in, and especially if they have a hospital bed, looking at different types of pressure relief and that sort of thing as well. In terms of vitamin D, I mean, I certainly would not be making comments about that. I might just flag it to them to talk to their doctors. Dr. Kitamura might be more likely to talk more about the vitamin D component.
Yeah, I'm not as certain of evidence around vitamin D for sleep. If anybody else does, I'd be happy to hear it. Not something that's in my toolkit right now, but maybe there is some if people can share. I'll just comment on the piece about the sleep study. So again, not everybody with sleep difficulties needs a sleep study. Often, you know, trying to confirm if there is a sleep apnea or abnormal movements during sleep, or if we're stuck, it can be helpful. And there are some, you can actually do home polysomnograms now. And I imagine in facilities as well, where they do it, it's simplified. The traditional way is people would go to a sleep lab and get hooked up with, you know, all over the body with different sensors. But now there's ways where you can just get measure a few of the important things, and it's a much less obtrusive and can be done in the home. So talk to your local sort of sleep labs. Many of them do offer that.
And then Robert was asking about skin rashes that persist on residents' arms, climbing out of bed, current UTI being treated, skin rash. Any ideas? I was thinking of cream, allergies, detergent used to clean bed sheets. Certainly, I mean, from a non-pharmacological perspective, I would look at all those options in terms of what the material of their bedtime attire is. And the sheets, of course, I don't know, from a dermatological perspective, I mean, maybe getting a dermatologist involved for that one as well to see what's going on.
Right, so we are at time. There is so many great suggestions and information that was shared in the chat. I want to again really thank our speakers today for a very stimulating presentation and very useful, I can tell by the chat and the responses on the screen. Cara and Chris, take a moment to read them and soak them in. I also want to thank Stacy Guy and Agnes Chang that are behind the scenes operating this and making this flow seamlessly and well. Please respond to our evaluation questions. We rely on your responses. And again, thank you everyone for joining us today. Take care.
Thanks, everybody.
Thank you.
Okay.